good morning to all. My name is Dr. Ernest Po, and I'll be moderating the second session. So let me introduce our speaker for today. He is none other than Associate Prof. Dr. Wong Kuan. Dr. Wong is a consultant respiratory physician who received his first degree from UKM. He then obtained his MRCP in 2010 and completed his respiratory fellowship in in 2016. So he's formerly the head of respiratory unit in UMMC, and his main interest is in managing obstructive lung diseases such as severe asthma and COPD. So he's a trainer for the Malaysian Thoracic Society Spirometry Workshop and committee member for the Malaysian Thoracic Society Inhaler Education and Training Steering Committee. So Dr. Wong actively trains nurse educators for management of asthma and COPD through various workshops. And today he will be speaking on a topic that is very close to his heart, which is COPD, on the topic on reduced COPD, a holistic approach for COPD management. So Prof. Wong, the floor is yours.
Thank you very much, Professor Ernest. Thank you, everyone, for dialing in to this morning. I would like to share my slide first. So I'm a chest physician managing obstructive airway disease, and I have been so far involved in managing patients' educations as well as nurses' education in regards of management of COPD in our hospital. So the topic of my lecture today will be Reduced COPD Program, a holistic approach for COPD management. Just a bit about what is COPD. COPD is actually a chronic obstructive pulmonary disease. It is a very common and preventable disease, and this disease is treatable. As you can see in this diagram, there's airway inflammation as well as airway narrowing that causes the hallmark characteristic of persistent respiratory symptoms and airflow limitation. So all this is actually influenced by the host factors, including abnormal lung development, and definitely the more important is significant exposure to noxious particles or gases. The noxious particles that usually account for this condition would be cigarette smokes. And diagnosis of COPD is basically based on the patient's symptoms, whereby the patients usually come in with breathlessness, chronic cough, and sputum productions. And at the same time, we clinicians will try to link the patient with any potential exposure to the risk factors, such as tobacco use, occupational related, as well as indoor-outdoor pollutions. And to confirm the diagnosis, we usually have to do a test called spirometry, or we usually name it as layman as lung function test, to look at the post-bronchodilator, whether the FEV1 over the FVC ratio is less than 0.7. And this will confirm the diagnosis of COPD. You can see that in this gentleman, he's actually sitting in a tripod position, which is like the hallmark of advanced COPD patients coming in with severe malnutrition and muscle wasting. And at the same time, they are in respiratory distress. They have to actually stabilize their body to make sure that they can use their accessory muscles to breathe. And definitely when they come in the emergency department, they actually have symptoms such as wheezing and chest tightness, and most of the time it can be labeled as heart disease, heart attack as well. And when you get a chest x-ray done, you will see that the patient actually has a very hyperinflated lung. As what I mentioned just now, if the spirometry will be the gold standard for the diagnosis. And furthermore, if you want to know the lung structures in detail, you can actually proceed with a HR-CT scan, and you can see that the patient has obvious emphysematous lung changes. So COPD is actually a very major healthcare burden and causes a high mortality worldwide. It's about almost 400 million people actually affected by this condition. We can say it's 1 in 10 of the adults actually having COPD. And 50% of these patients, majority are underdiagnosed because of lack of awareness as well as lack of a diagnostic tool in the clinic. And it is the second most common cause of emergency admissions in some countries. And 40% of these patients, after admitted to a facility with a COPD exacerbation readmitted 90 days and with another exacerbation. And COPD has been found to be the third leading cause of death worldwide, accounting for about 3 million deaths yearly. What about COPD in Asia Pacific? Overall, it's estimated about 6.2% of the prevalence of COPD in this region, with 19.1% of these subjects actually having severe form of the disease. Almost half of them actually experience exacerbation within a year, and quarter of them require emergency department visits, as well as 20% of them hospitalized for exacerbation. In Malaysia, there's a paper by the primary care actually noted that the prevalence was estimated about 4.7%. And there's many challenges in the sense of management and diagnosis of a COPD in Malaysia. First of all, there's lack of awareness among the clinician as well as the patient, and there's limited access to diagnostic tools. There's multiple complex comorbidities among these patients as they are older generation with multiple medical problems. They have a limited access to specialist care. Majority of them actually presented first to the primary care physicians for simple respiratory infection, but was missed and underdiagnosed as COPD. And there's also a lot of stigmatizations and social factors that prevented all this group of patients coming to seek for help and also medical treatment. And definitely at the point of time, there was lack of a personalized treatment in this group of patients. Not only that, when you encounter a patient with COPD, they just don't come with one disease, they come with a huge package. They can come with multiple medical comorbidities, such as respiratory comorbidities. I've seen a lot of lung cancer patients who actually with symptoms of respiratory condition that mimic COPD, as well as there's also patients with coming with bronchiectasis as well. And definitely they will have other important cardiovascular conditions such as hypertension, heart failure, ischemic heart disease, and pulmonary hypertension. And because of recurrent exposure of oral corticosteroids, there are higher chance or risk of developing other metabolic comorbidities such as diabetes, as well as osteoporosis. Because of the ongoing deconditioning, majority of them actually have cachexia as well as skeletal muscle dysfunction. Because of this condition is non-reversible and it is progressive, majority of them actually had some form of psychiatric problems such as anxiety as well as depression. And COPD has been found to be one of the highest cause of hospitalizations among the major chronic respiratory diseases in Malaysia, and it's account about 40% of the admissions for the respiratory conditions requiring admissions in the Ministry of Health hospital. And it's also been found to be leading cause of death, second to the lung cancer in the Ministry of Health facilities as well. This is the main problem. There's low awareness of COPD among our population, and it is proven in this paper showing that majority of us actually never tell our patients that they have COPD. They were always being told to have chronic bronchitis or other terms like emphysema or bronchial asthma. The other issue is there's low utilizations of pulmonary function tests. And in this study has shown that only 37% of those suspected to have COPD patients will be having a lung function test. And 89% of these patients do not know what is their lung function after the test. this COPD exacerbation is a huge problem, particular not just in Malaysia, also worldwide. And about 31% of the exacerbation actually require emergency department visit, and almost 20% of them would be hospitalized. And 24% of them will be readmitted within 30 days of discharge. And again, 40% of these patients will readmit or die within the 90 days of discharge. And there's a retrospective studies conducted in both Hospital Chancellor Tuanku Muskris and also UC Malaya Medical Center, which shows that the readmission rate for the COPD patients are very high. It's about 33% to 20% in our cohort. And majority of these patients, they actually have preventive measures to be taken, all right? All these triggers are able to be prevented, such as smoking, non-adherence to medications, poor inhaler technique, as well as so-called non-vaccination for the common flu and also pneumonia. So this is a study conducted in multi-center in UNIC Malaya, in Institute Purwakarta Respiratory, as well as UITM. And we look at a whole lot of COPD patients, and we screened about 3,000 of them, but only 450 of them actually fulfill the inclusion criteria. And we look at their outcome after the first exacerbation. So majority of these patients actually succumbed to respiratory complications, whereby about 60% of these patients were classified to be in the very advanced stage of a COPD, which is grade 3 and 4. And so it concludes that severe COPD actually will increase the risk of mortality as well as respiratory-related mortality. Hence, it is important to diagnose COPD early, as well as become more proactive in the sense of management of this group of patients to prevent further decline of lung function, as well as to prevent the premature death among these COPD patients. So there's a lot of gaps in the COPD care in Malaysia. Particularly, you can see that when the patients being admitted due to a COPD exacerbation, they are being placed into either a general ward or to a specific respiratory ward. So the patients will be reviewed and managed by new or rotating physicians, which is showing there's an inconsistency in the management, as well as some of the time the management was not following the appropriate guideline. So when the patient is in the ward, the patients are being reviewed by the rotating MO and the specialist. And definitely following that, the patient was being discharged from the home to the home without a proper specific discharge criteria. And there's a lot of time these patients actually missing the post-hospitalization care after being discharged. And hence this will actually affect their treatment plan. And majority of the time, the treatment is not being optimized before discharge. So to address this unmet need, hence there's a need to design a COPD discharge protocol. And this has been proven to be important in the sense of reducing the readmission rate among the COPD patients. So this group of experts actually comes together and design an appropriate COPD discharge protocol and recommend it to be used for purpose of prevention of COPD exacerbation. And in fact, in the systemic review, shows that almost about 20% of the reductions of the COPD readmissions after the use of this important COPD discharge protocol. So what is happening in UMMC? As you can see, what is the strategy that we are using to improve our COPD management care is by initiating a program called Re-Engineered Discharge COPD program, which is a nurse educator program. So we have been to train all the nurse in the medical respiratory ward in the sense of managing the COPD patient. It has been ongoing since the year 2019 until now. And we also have gone through the period whereby there's a COVID pandemic, and we are facing a lot of challenges while training the nurses as well as managing COPD patients as well. And furthermore, last year we started to implement a strategy called COPD discharge protocol. Basically, the main purpose is to reduce the readmission rate or improve the reduction in the readmission rate after initiation of the discharge protocol add-on to the COPD nurse educator. And for this year, we started to implement a new framework of COPD management, which we call it COPD Reduce. And this is basically to diagnose high-risk patients in the primary care setting and to identify patients at high risk of exacerbation early and to optimize their treatment before they being admitted to the hospital. Just would like to tell you about what is a RATE COPD program. Re-engineered discharge COPD program is actually adapted in a program from the Boston University, and we have developed a module, a training module, which includes 12 chapters in the sense of including all the management of the COPD. And we have used this module to train our nurse educator twice a year. And we have majority of the group of the nurses being attached in the respiratory ward as well with the training logbook. And they have to actually have some form of a practical experience in the sense of managing COPD patient and educating patients in the ward. And last year, we have started the COPD discharge checklist. And this discharge checklist is implemented in the ward to make sure that the patient has gone through the important treatment prior to discharge. So these are the important chapters that's available inside the training module booklet. And we have the first one-day training workshop in 2019, November. And that's where we bring everyone together, including the nursing department, the rehab department, the pharmacists, as well as the dietitians. And we actually have one whole day of workshop teaching the nurses on how to use the inhaler, on how to counsel patients in the diet, as well as exercise program. And this is where we actually had a workshop at the primary rehab area, in the sense of looking at the COPD patient on how to do the primary rehab program. So to create the discharge protocol, it's very easy, and we actually use evidence-based information that align to the guideline management of the treatment, as well as it can be customized to any individual hospital. So this important thing is we have to have patients' details so that we can track the readmission. We ensure that the patient is being referred to the smoking cessation clinic, and we have all the related investigations put into the checklist. And of course, we ensure that there will be a primary rehabilitation referral being made in patient, and also as well as the outpatients primary rehab. Definitely, the doctors will have to look at the list as well, and to optimize the treatment according to the guidelines. And we'll check the patient's inhaler technique as well as to manage the patient's comorbidity. And furthermore, our nurse educator will give counseling as well as education for the disease and also the inhaler technique, and will arrange for the appropriate appointment within 2 to 3 months, and definitely to remind the doctors in the sense of to vaccinate the patient before discharge. So with this checklist, we hope that any physicians can use it and then to make sure that the patient has gone through the necessary treatment before discharge. And definitely the treatment will be more appropriate, more consistent, and therefore this will improve the outcome of the patient. I just want to tell you about the framework of the COPD reduced in UMMC, and we have 3 pillars. The first pillar is to accelerate the COPD diagnosis, whereby we will start doing spirometry assessment in high-risk group patients in the primary care clinic to diagnose the COPD early. And when the diagnosis is being made, the patient can be initiated with treatment as well as referring to the respiratory clinic for further treatment. And definitely we want to make sure that this group of patients that we are seeing in the clinic and assess them whether they have high risk of exacerbation. If at all they have high risk of exacerbation, we would optimize their treatment before being admitted to the hospital. And for the pillar 3, this is to make sure that the patient do not re-admit after the index admission by implementing the discharge checklist as well as referring them to pulmonary rehab early, in sense like improving their functional status as well as reducing the deconditioning in this group of patients. So I'd like to just show you that we have the first launch of our portable spirometer in the UMMC primary care clinic, and that is Prof. Camilla receiving the so-called the spirometer as well as training material from the respiratory unit. And we have the first UMMC primary care spirometry workshop on the 26th of July, training a group of nurses as well as doctors. And we are ready to actually implement the pillar 1 strategies in our UNIC. And for the pillar number 3, which is preventing the COPD readmission, we have done a so-called audit in 152 patients. And from this group of patients, we have make sure that they have been discharged with a checklist, and we have assessed their outcome. And we found that still there's a lot of patients not being assessed with a spirometry. And again, there's a lot of patients being admitted with a respiratory infection as well. The good thing is about this checklist is we have increased the referral to pulmonary rehab. There's about 83% referral for inpatient pulmonary rehab, and there's increased almost 200% of recruitment into the outpatient pulmonary rehab program. And the other thing we found that the patients are more likely to be vaccinated after we initiated the discharge protocol. At the same time, our nurse educator is able to document down that they have actually teach the patients on how to use the inhaler correctly. And we noted that there's only quarter of our patients have good inhaler technique, and majority of them will need a spacer to use the inhaler properly. So in all, this COPD discharge protocol actually able to reduce 35% of the readmission in 30 days as compared to the standard of care. So in summary, COPD is a high burden and complex disease, and management of COPD requires multidisciplinary approach. Readmissions of COPD is a major issue and is a burden to our healthcare, as well as there's a lot of gaps in the sense of the COPD care in Malaysia hospital. And to so-called improve the management of the COPD patients, the COPD discharge protocol is an evidence-based tool, and this is proven to reduce the readmission rate in our center. And of course, UMFC COPD reduced framework is an integrated MDT approach that targets on early proactive intervention to improve diagnosis and to identify at-risk patient of exacerbation as well as improving the patient's outcome. So before I end, I just want to show that we have conducted some events over the past few years. We have organized a UMFC World COPD Day celebration in year 2024. And as well, I would like to show that our program has actually been recognized by the Malaysian Public Relations Award 2024, and we have received a Gold Award in the healthcare. And the team is growing as years goes by, and I'm very glad to have this team working hand in hand together with me in sense of improving the COPD management in our hospital. Thank you for your attention.
Thank you, Prof. Wong, for the very interesting lecture and highlighting the work that you have done over the years. Can I open the floor now for any questions? So if there are no questions, then allow me to ask some questions. So Prof. Wong, you mentioned that now it's all about empowering the primary care physicians so that any physicians can diagnose COPD. But I still see that a lot of the work has obviously, I mean, COPD is a respiratory diseases, and a lot of the work at some point will still be channeled to the respiratory physician, rightly so. But as you know, our numbers are very limited, and is there a way that we can incorporate them to the treatment of COPD as well, or to referring the suitable patients for rehab and stuff like that? Is there a strategy to empower the primary care level to do this as well?
Yeah, that's a very good question. We have been starting to, first of all, train the primary care physician to be more confident and also more comfortable in managing COPD patients. So there's a ongoing roadshow, in fact, in the Ministry of Health, and as well as in our own backyard as well. And we've been trying to incorporate the sort of like the knowledge of the management of COPD in the primary care physicians. Not only that, it's the workshop also training the rehab medicine specialists and also palliative care physician as well. So there will be a lot more people able to be understand the management and the treatment of COPD. And for sure, like primary care physician, they are empowered to actually initiate treatment, all right? And I don't think it's just basically the chest physician has to manage all the COPD patient, because it's not right just to send to us when the patient is being diagnosed in the advanced COPD. So the most important thing for this strategy is to diagnose them early and then initiate treatment as early as possible. And I think each and every physician has a role to play. And this is a very common disease, as what we have shown that the prevalence is about 4 to 6%. And you'll be seeing a lot of COPD patients as years goes by because of aging population. Hence, I felt that each and every physician has responsibility to diagnose early and to initiate the treatment as early as possible. So the empowering of the treatment would be to all, but for advanced cases, complex cases, definitely the management would be under us.
Okay, in the interest of time, there are 2 questions online. Can you keep the answers as short as possible, Dr. Wong? What is the role of imaging in the management of COPD?
Okay, so the imaging is basically just to look at the emphysematous lung changes, and as well as whether can we use intervention to improve the patient's symptoms as well as the lung function by doing a lung volume reduction intervention or surgery.
Okay, and the other questions by Prof. Koo, will these be adopted and implemented by other centers nationally? I suppose it's referring to all the work that you've done with the UMMC Reduce COPD program.
So far, there are few centers that are being identified to run this project, including UNC Malaya, and the other center will be Hospital Selayang and their sister hospitals as well. So it will be conducted as a small scale, but what we want is to show the nation that this works, and of course we'll disseminate it to the rest of the center as well.
Okay, so if that, thank you, and I would like to congratulate Associate Prof. Dr. Wong for his recent promotion, as well as all the work that he's done over the years. And I thank you everybody for participating in the webinar today. Thank you.
Thank you very much.